So, welcome to the next of our lecture series covering the initial assessment of competencies for novice anaesthesia. This lecture will cover the choice of post-operative analgesia, and it is linked to the curriculum IAC C05. The learning objectives covered in this presentation will include considering the patient in predicting the likely severity of post-operative pain, and dividing the factors to consider into patient and surgical factors, understanding why keeping post-operative pain to a minimum is of key importance to the anaesthetist, and prescribing effective analgesia for use in the recovery post-operatively and on discharge to the ward or home. So here we have shown the IAC code that will be covered in this lecture, and the key one being discuss how the trainee's choice of post-operative analgesics was made. And below we have listed a number of the curriculum items that could be linked to this. These are taken from Annex B and will ensure that you maximise each work-based placed assessment that you do. Here you can see the case-based discussion page on the lifelong learning platform, and we can see below where you can add in the initial assessment of competencies code, and above where you can add additional competencies that might be relevant to this assessment. So just starting with a simple definition of pain. Pain is typically defined as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Some pain in the post-operative period is normally expected following an operation, though good pain control post-operatively is a key aim of good perioperative care. The incidence of moderate post-operative pain ranges from about 50% to 75% of patients. So why is good post-operative pain relief important? The negative effects of post-operative pain control are vast, and I've listed a few here which we'll go through now. So severe post-operative pain can result in nausea and vomiting, and this has associated complications, for example, wound dehiscence, negative patient experience, and raised intracranial pressure, which could be very clinically significant in cases of neurosurgical procedures. In the cardiovascular system, post-operative pain may lead to hypertension and tachycardia, which could compromise hemodynamic stability, particularly in at-risk patients, for example, patients with poor systolic function. Post-operative pain can increase the risk of developing a post-operative pulmonary complication due to shallow breathing. Particularly, this is a risk in abdominal and thoracic procedures. Longer-term, severe post-operative pain may lead to sleep disturbance with associated negative effects on mental health. It can limit and delay patient mobilization post-operatively, which can result in increased risks of post-operative complications such as VTE. And finally, severe post-operative pain can result in a negative patient experience, which can lead to fear of further medical interventions that might be necessary and damage the patient-physician relationship. There are a number of factors to consider when deciding on a post-operative analgesic strategy, and I have tried to divide these up in order to try and make them easier to think about. So first, factors that we can think about when we're trying to predict the severity of post-operative pain, and these can be divided into patient and surgical factors. And then factors affecting the choice of the post-operative analgesics. So I've divided these into patient, anaesthetic, and surgical factors. Predicting how much pain a patient might be in following an operation is a difficult skill and one that requires much experience. When thinking about patient factors to consider, the anaesthetist must consider any pre-existing pain that the patient might be experiencing and analgesic requirements pre-operatively. For example, patients that are suffering from chronic pain. Clearly, post-operatively, this chronic pain will remain and is something to take into account when prescribing a post-operative regimen. And also, it is very important to consider a patient's expectation of pain severity post-operatively. It is our job as anaesthetists to ensure that patients are as prepared as possible for their operation, and this includes a realistic expectation of the pain afterwards. A few surgical factors to think about when trying to predict post-operative pain include the site of the operation and the operation itself. So the pictures in this slide illustrate some extremes, but clearly the injury on the right is going to need a very different analgesic strategy to the one on the left. Positioning during the operation can contribute to the levels of post-operative pain. For example, lumbar back pain following the lithotomy positioning, which also links into the duration of the surgery. Though, as careful as we are with patient positioning intraoperatively, prolonged procedures in awkward positions can contribute to pain postoperatively. So moving on to the choice of postoperative analgesia, I again have tried to divide these into patient, anaesthetic and surgical factors to consider. So clearly allergy is essential to know and clarify before starting any anaesthetic, and it is certainly relevant to prescribing analgesia postoperatively. Age is relevant to both the choice of analgesics and also the dose. For example, it may not be appropriate to prescribe NSAIDs in more elderly patients, and we also must be very cautious when prescribing opiates to pre-existing pain and any medications that patients may be taking for this definitely come into consideration. For example, it might be wise to stick with an opiate or analgesic that a patient is already on in the post-operative period. And dosing of opioids is going to be very different for patients who are taking these long term as opposed to our opioid naive patients. A thorough pre-op assessment includes evaluation of the regular medications that patients are taking preoperatively, and this is important when prescribing post-operative analgesia so that we can be aware of any potential interactions that might occur. Patient comorbidities may significantly alter the pharmacokinetics of drugs prescribed, particularly renal and hepatic impairment, which can affect the metabolism and excretion of many of the commonly prescribed analgesics. Other comorbidities, such as mental health issues and opioid dependence, may present particular challenges when choosing post-operative analgesia, and often specialist help may need to be sought in these cases. Finally, it is important to consider patient factors that may limit the delivery of drugs. For example, when considering controlled analgesia systems, these may be inappropriate in patients with Alzheimer's disease or those with neuromuscular disorders. A few anaesthetic factors that may affect the choice of postoperative analgesia include the use of regional anaesthetic techniques. For example, peripheral nerve blocks or neural axial techniques may reduce the need for oral or intravenous analgesia postoperatively, though careful thought needs to be considered for when these wear off, especially given as the patient may be discharged from the recovery area at this time back to the ward. Pain-killing medications are often given intraoperatively, and many of these, such as long-acting opiates, will be having an effect into that immediate post-operative period. This should hopefully ensure that patients don't wake up in severe pain with all the negative consequences of this. And finally, some surgical factors to consider for the choice of post-operative analgesia. Elective versus emergency can present their own individual problems. Generally, in an elective surgery, there is more time to prepare the patient and manage expectations for postoperative pain. And for emergency cases, many of these in their presenting complaint will be in pain, for example, trauma. So analgesics prescribed here may affect the choice of the regimen prescribed for postoperatively. Generally, patients who have come in for expected day case surgery, the aim would be to have postoperative pain well controlled on simple oral analgesia, for example, paracetamol and NSAIDs, as this is what patients will be able to take on discharge home. But for patients having a more complex surgery and a planned inpatient admission, more complex multimodal strategies may be possible in the postoperative period. When considering the surgery undertaken, it's important to think about what the potential consequences of the surgery might be on the absorption, metabolism, or elimination of analgesics prescribed. For example, patients undergoing major GI surgery are at increased risk of postoperative ileus, which means that any drug administered via the enteral route may not be adequately absorbed. For some surgeries, such as oral or maxillofacial, it may be, in fact, painful to even administer medications via the oral route in the initial postoperative period. Traditionally, pain relief guidelines have been based on the WHO Analgesia stepladder, but a move away from this to a more multimodal analgesia has been shown to be beneficial. It has been shown to obtain optimal analgesia through targeting different pain pathways while limiting overall analgesia-related side effects. Additionally, many trusts have introduced standardized protocols for pain relief for specific operations. For example, in orthopedic surgery, many trusts have a standardized multimodal plan, which can be adapted for each patient. It is essential that these protocols are adapted for the individual patient. This is because comorbidities, as we discussed before, can have a very significant effect on the absorption, metabolism, and excretion of different postoperative analgesics, which may affect the choice and the dose of drug prescribed. So, starting with paracetamol, the most commonly prescribed postoperative analgesic, it is also often given intraoperatively for pain relief postoperatively. It should be prescribed to most patients regularly following an operation. It is opioid sparing, it has minimal side effects, and it is included in most of the standardized protocols. It is administered most commonly through the oral, intravenous, or rectal route, and the rectal most commonly being used intraoperatively. The dosing of paracetamol intravenously is 15 milligrams per kilogram, and orally for adults is 1 gram 4 to 6 hourly. It is essential to bear in mind patient weight when prescribing paracetamol, particularly intravenously, and also particularly in a normal dose of paracetamol is generally considered safe in patients with mild hepatic impairment, though adjustments will be required in patients with severe hepatic impairment due to paracetamol's metabolism and excretion. The mechanism of action is not fully understood, but is mainly thought to be through the inhibition of the cyclooxygenase enzyme system. Side effects are few and true allergy is very rare, which is why paracetamol is such a safe and effective drug to use in the postoperative period for pain relief. Non-steroidal anti-inflammatory drugs are an effective option for regular analgesia postoperatively for mild to moderate postoperative pain, but only if there is no contraindications. Drugs available for use can be subdivided into non-selective and selective. COX inhibitors, with non-selective including ibuprofen, diclofenac, naproxen, and ketorolac, and an example of a selective COX-2 inhibitor being paracoxib. There are many significant contraindications to NSAIDs, and it is essential that we are aware of these. Most are relative contraindications, and it is our job as anaesthetists to weigh up the risk-benefit of these. They include age, with the increase of the side effect of gastrointestinal bleeding increasing in the older patient. Caution must be used in patients with significant renal disease. Patients with asthma may often not be able to have non-steroidal anti-inflammatory medications. They are contraindicated in pregnancy due to premature closure of the patent ductus arteriosus. They also increase the risk of significant bleeding, so in operations where this may be very significant, such as spinal or ophthalmic surgery, they are often avoided. One of the key side effects of NSAID medications are the risk of peptic ulceration. This is particularly with extended duration of the use of NSAIDs, so not normally an issue when using in the acute postoperative period to treat pain. But of note, stomach protection must be considered in all patients receiving regular NSAIDs, and this is a recommendation by NICE, and it is for anyone over the age of 45. Opioids are commonly prescribed in the postoperative period, especially when severe pain may be expected. They include weaker opioids such as codeine, dihydrocodeine, and tramadol, and more strong opioids for severe postoperative pain such as morphine, oxycodone, and fentanyl. The opioids selected to treat postoperative pain may be dependent on the absorption and the route of administration. For example, in patients, as we discussed before, with post-operative ileus, these may need to be delivered via the intravenous or transdermal route. And the drug selected may depend on the predicted severity and duration of postoperative pain. So for patients who are planned as a day case, it might be more appropriate to use a shorter acting opioid such as fentanyl to manage their pain postoperatively. But for more complex procedures where patients have a planned admission and we know that you're going to want that analgesia to continue in the longer term, then a selection of a more longer acting opioid. Some opioids such as morphine and oxycodone come in modified and immediate release preparation, with modified preparations being longer lasting, usually over the course of about 12 hours. These may be appropriate choice in patients needing analgesia for 2 to 3 days postoperatively, but it is also important when prescribing these to prescribe some immediate release for breakthrough pain for any episodes of severe pain in that immediate postoperative period. The side effect profile of opioids is extensive. They are emetogenic, can cause significant constipation, and also pruritus is a common side effect. It is considered good practice to co-prescribe antiemetics and laxatives for patients who are prescribed strong opioids, particularly in the longer term. Particular caution and consideration needs to be given when prescribing opioids to the elderly population, with generally smaller doses being used in this group. Renal impairment can significantly affect the elimination of opiates, and if consideration to this is not given, this can result in very significant side effects. Here I have created a flow diagram to give a rough guide as to what opioid might be appropriate to prescribe in the postoperative period. It is by no means exhaustive, but hopefully gives an idea of what might be appropriate to prescribe depending on whether it's a minor or day case operation or a moderate or major operation with increasing severity of pain expected. It's really for adult patients who are not taking regular opioids preoperatively, and for patients where we're not suspecting any issues with enteral absorption of medications. So for a minor or day case procedure, a prescription of an opioid is by no means necessary, but if it is thought one is required, a shorter acting opioid, for example fentanyl, might be appropriate for these cases. As we increase in operative severity, a short acting opioid for use in recovery might be useful, for example fentanyl, and an additional prescription of an immediate release opioid for use in the recovery or on discharge to the ward, for example immediate release morphine or oxycodone at appropriate dose. And for more major operations with expected high severity of postoperative pain, you could consider prescribing a short course of a regular modified release preparation of an opioid, for example modified release morphine or oxycodone, with an appropriate prescription of a breakthrough dose of that same opioid, normally at approximately 1/6 of the total 24-hour dose. Moving on to some classes of medications that are not so commonly prescribed in the postoperative period, but can be highly effective postoperative analgesics. One of these is neuropathic agents. These are often included in some trust surgical protocols for major procedures such as in orthopedics. Examples include gabapentin and pregabalin. They are useful adjuncts to manage severe postoperative pain and are not normally used in isolation. They are normally considered most effective when initiated preoperatively and then continued in the acute postoperative period. And finally, some other agents to be aware of that can be used to treat postoperative pain. These are non-opioid medications that can be added into the multimodal regimen when pain control remains suboptimal, or in patients where there's a specific need for avoidance of opioid drugs. It is important to note that if pain postoperatively is grossly out of proportion with what is to be expected, this may prompt further investigations and even further surgical review. And also, as a novice anaesthetist, when struggling in cases of severe postoperative pain, specialist advice and senior support should definitely be sought. So ketamine, which can be used to treat postoperative pain, is an NMDA receptor antagonist, and the dose for effective analgesia is 0.25 milligrams per kilogram intravenously. It is an effective analgesic but has a variety of side effects, including psychiatric, cardiovascular, such as increased heart rate and blood pressure, and hypersalivation. The alpha-2 agonist clonidine has been proven to have effective analgesic effects and can be used in 3 micrograms per kilogram intravenously. Its side effects include a drop in blood pressure, and also it can be sedative. Magnesium is another drug that can be used as an analgesic. It is given via a slow intravenous infusion, normally of about 2 to 2.5 grams. Its side effects include hypotension, muscle weakness, and arrhythmias, particularly on rapid infusion. So just to recap after this lecture, just to recap after this lecture, hopefully you will now have an understanding of why minimizing postoperative pain is important and is a key role for us as anaesthetists. Have an idea of how to assess and plan postoperative analgesia for the patient as an individual. Thank you for watching, and if you can, and we would appreciate it if you completed our short survey monkey in order